This is a case of a 26-year-old male patient, victim of robbery with a non-lethal gun and a facial trauma, who was admitted to the ER with a visual acuity of count fingers on the left eye. During the initial exam, it was evident a dense vitreous hemorrhage on the left eye. CT images show ethmoid and orbital floor fractures, as well as localized choroidal hemorrhage. Ultrasound shows vitreous hemorrhage, choroidal detachment in 4 quadrants, and intertemporal choroidal hematoma. 20 days later, worsening of visual acuity, improvement of vitreous hemorrhage, as well as an image suggestive of temporal retinal fibrosis were found. A diagnosis of chorioretinitis sclerotiria, vitreous hemorrhage, and inferior retinal detachment was made, and a PPV was indicated. During the procedure, careful removal of anterior hyaloid with blood was performed. Vitrectomy was complete, finding total retinal detachment. Remnants of very adherent hyaloid and blood were found in the macular region, so they were removed with ILM forceps. A traumatic macular hole with the presence of foveal subretinal fibrosis and traction that extends towards the upper perifoveal region was found. PFO injection was made, finding a complex network of subretinal fibrosis in the posterior pole, so a retinotomy was performed with subsequent fragmentation and extraction of the fibrosis, achieving adequate relaxation of the foveal region. During removal of temporal fibrosis, there were strong adhesion to the retina, and a retinal rupture was created, which was used to release peripheral traction and allow removal of the complete band of subretinal fibrosis. Retinotomy edges are cauterized and the peripheral carbon is removed to proceed to disconnect subfoveal fibrosis. ILM staining with chin blue is performed, and creation of an inverted flap was made, releasing 360-degree traction around the hole. Temporal subretinal clot was removed, finding a bleeding choroidal vessel. Cauterization was performed, achieving hemostasis. Peripheral vitrectomy was completed, finding temporal retinal holes of the causative lesion of the retinal detachment, so removal of the hyaloid was done, as well as the epiretinal blood. Anterior vitreous shaving was performed, and the inverted flap is repositioned in the macular hole. Fluid air exchange was made, and the laser is performed around holes and in 360 degrees. With silicone oil endotamponade. One month later, visual acuity is 20/200 with eccentric fixation, and although the OCT shows closure of the macular hole with parafoveal fibrosis, there's presence of severe linear RPE defects that involves the foveal region that can be better visualized in autofluorescence images, what explains the final visual acuity.